of you already know who Scott Griffith is. He's the government relations treasurer, executive director, worker bee, all kinds of stuff at Wisconsin PVA. So he's the face. But he's going to start out the talk. Hopefully you can learn something from this, and also he will introduce the guest speaker that has also come up here to give us a talk as well.
Great. Thanks, Dr. Lee. I'm going to drop this so I can be loud and can be heard, because we are recording for the folks who can't be here this afternoon. I promise I'll stay away. Just up here somewhere. So as Dr. Lee said, I'm Scott. I'm with the Paralyzed Veterans. I've got a long military family lineage. I'm 8th generation combat veteran. So I promise you will learn something today, even if it's a personal trivia about Scott. You'll walk away with something new. But we've got some good information, and we're going to challenge you to think today about disability awareness and disability etiquette. And I look forward to your interaction and your experiences that you bring from the patients and veterans that you serve every day. And we can't thank all of you enough for what you do for our veterans, because without you, a lot of us would not be here alive in person. I'm a unique spinal cord guy. If you haven't had a chance to peek in my chart, I'm one of the anomalies, the walking guys. I have a spinal cord tumor. And I've had a tumor inside my spinal cord for 24 years. And it's been surgically excised twice. And every time they cut into the spinal cord, they do all sorts of nice damage, which creates some limitation. I've rehabbed myself out of a chair twice. The first time was very difficult. It took about 2 months before I could even fathom putting my feet on the floor. I had the neck the size of Jabba the Hutt, and just mentally couldn't process it. I was literally if you Tim McGraw, I was in my early 30s with a lot of life before me, and when a moment came and stopped me on a dime, and it did, and it was the discovery of that tumor in my cord. So I've lived with that now for 24 plus years, and I'm still in the fight and going strong, and it's because of you and the great work that you guys do that keep myself and my peers within the spinal cord injury veteran network alive and kicking. So thank you. Real quick, man, you're on it, dude. These are terms that you guys are familiar with. You received this in your training. These are the classifications of the SCI groups and the major SCI disabilities. The interesting thing is what causes these categories of disabilities. We have everything from military sexual trauma, domestic abuse, DUIs, whether it's the person driving who's intoxicated or being hit by an intoxicated driver. We have combat, direct fire, indirect fire, there's fratricide, there's suicide. There are veterans that you guys take care of that are here because they attempted suicide. And it's very important for you to know and to understand that veteran and the world that they come in, before you seek understanding of what your mission is today to go in there and treat that veteran. Because trust me, all of these veterans, just as you, have triggers that can bring up an experience that you may have had occur during your life. Again, more of the subsets, the spinal cord tumor guys, the Guillain-Barré syndrome guys and girls, the blood disorders that we have and that you've seen that cause spinal cord injuries. Anything that you've experienced that wasn't up there, underlying disease that caused the spinal cord injury. Dr. Lee, what do you got?
So spinal cord injury, you got some neuromuscular diseases that come out, and we see them occasionally. Don't forget the ALSs, MS with the cord involvement. But looking at the disability in general, it's more than spinal cord injury. That's also important to amputees, stroke, right?
Absolutely.
Make sure to think about beyond spinal cord injury, because this etiquette goes to them as well.
It does. It goes to all persons. It even goes to persons in your households. You know, people that we interact with on a daily basis at the grocery store, at church, at work, social groups, you know, wherever. As you'll hear more, I'm more focused on the veteran perspective, but you'll hear our guest speaker talk about, you know, some more instances and things like that. You know, the silent type disabilities are what you really have to be aware of, because, you know, you may perceive someone as ignoring you and they're truly not. You know, maybe it is a hearing impairment. So you really have to understand the person, you know, that you're working with and get to know them. PTSD is a big one, very common one. Underlying disability or secondary disability or tertiary disability in the world of veteran disabilities. There are many triggers. I'll open it up to you guys because you know very well what could possibly trigger someone to have a reaction to whatever that trigger was, whether it was slamming the door or escalating your voice or entering into a confrontation. What have you seen? Give me some examples, somebody please. Anybody, throw it out there.
You turn the
Michelle.
light on at 3 o'clock in the morning and you get a little upset because you don't want to trip over the wheel.
Spot on, especially when you only hear as a lodger. Not that I've experienced that. Michelle.
I'm getting older now, I'm a little more tripping over things in there.
Dropping a slide board on the floor.
Absolutely. Yeah, anything that you know, causes a sudden noise or anything like that.
It's not the middle bedpans anymore.
We've come a long way. It could be movies. You could be real careful with movies and Hollywood's dramatization of conflict.
Yeah, I was going to say for my example that we have a lot of veterans who will leave the television on, you know, overnight while they're sleeping as kind of like helpful background noise. But sometimes when it's the news, especially if the person is confused and has some history of PTSD, you know, the announcements in the news about warfare or, you know, conflict or whatever, and then hearing those noises has triggered, you know, stress reactions from
Absolutely.
veterans when they wake up and hear that and they're startled and like, where am I? What's
You're
going
spot
on?
on.
Like we had Reclaiming Our Heritage, we had the Civil War reenactors here. Besides setting off the car alarm when they were shooting off the cannons, we were having some issues with some of the guys in the hospital with, you know how loud those cannons are. We're setting off the car, then they would set some of the, even fireworks, simple thing of fireworks.
You're spot on. Like I said, I'm 8th generation combat veteran. I grew up in a household where on the 4th of July, it wasn't just a dog under the bed, it was my dad under the bed. And it was because of those fireworks and what he experienced in Vietnam. So spot on. So just awareness of those things. You know, you don't want to set the tone of the atmosphere where you have to walk on eggshells, but you really need to get to know the veteran. And that's the important thing to drive home here. Yeah, go for it. We're evolving. You know, this is the society that we live in. And, you know, we want to stay away from labeling people and using insensitive labels when we talk about disability. And we want to present a very welcoming and inclusive environment and make sure that we are modifying everything, whether it's patient information, how they learn, you know, to them so that they can be successful in gathering that information and not have any stigmas of being associated and our label. Before I go, the next slide is introducing Jonathan. It is. So before I go into that, I'm going to do a little PVA plug here. Just by show of hands, how many of you know that PVA has a scholarship program for SCI professionals? Okay, keep those hands up. How many of you know that that scholarship can be used for more than just CRRN? All right, great, because it can. So we will help with CEUs or continuing education credits or things like that. Sometimes travel, if you're going to the PVA Summit, PVA National has a grant, and we can backstop that too. once you've been vetted through Dr. Lee and management accordingly for attendance to things like that. But we have some great scholarship opportunities. Without further ado, and I really encourage your interaction with Jonathan and pick Jonathan's brain and his experiences that he's had. We're very, very fortunate to have Jonathan with us today, Jonathan Heider. And without further ado, Jonathan, I'll let you take it from here. I got you. Yep.
No, hey, happy to be here. So I'm Jonathan Heider Laedtke, speaker sensitivity trainer. So I just kind of wanted to give kind of a basic overview. I know he had kind of talked about,
No, yeah, I jumped right to the end. That doesn't work. What? No? Okay. Let me get your slide there, cuz.
Yeah.
but throughout this, I just want to say I encourage questions. I encourage people to share stories, examples. Totally, this is more of a workshop base. In general, so totally open to bounce this around. Obviously, this is a safe space. This is kind of based on my own experience, my own knowledge, my own kind of research and education into that. So I just kind of want to talk a little bit about disabilities and background, kind of some common disabilities. I know he had touched on quite a few earlier. Some terms to know, terms to avoid, interacting, asking questions, and just being cognizant in general when it comes to people with different types of disabilities in general. It's kind of what we'll cover in this. You've got it in the booklet, so you can take notes there. Again, ask questions, share, as we kind of go along with this in general. So about me. So I'm a congenital quad amputee, so I was born with my disability. I was adopted from Croatia. I did grow up in the Green Bay area. Now live here in Milwaukee. I went to college here at UW Milwaukee. Got degrees in architecture and real estate development. Worked in that for a while, doing a lot of accessibility design, which has been fantastic as a background, but I'm doing a lot more on the keynote speaking, workshop facilitation. I have a background as a Paralympic athlete as well, as a Paralympic swimmer. Kind of see some of my experience there as an athlete. So my sport was swimming. I went and lived out at the Olympic and Paralympic Training Center in Colorado Springs, Colorado for about 2.5 years. You kind of see my accomplishments there during that time period. So, multiple American records, 2-time junior world, Parapan athlete, merchant team, yeah, it's all there. Did a couple things here and there.
That's good stuff.
A past life, the full-time life, but it shaped me into kind of who I am today and kind of introduced me into the advocating work. I know there's a lot of great, disability programs, now that we've got Wausau in Wisconsin, we've got Glassett just over the border down in the great, Chicago Northland area. So it's really great that, kind of starting to get people with disabilities out there and active and, kind of finding purpose in their life and finding ways to kind of learn discipline, learn structure, learn organization, and also socialization and ways to communicate themselves in general. So let's talk disabilities in general. So identifying somebody with a disability, I think everybody kind of has their own term that they lean towards. Some people find certain terms more offensive than others, and so this is personally, in my opinion, this is something that's more based on somebody in their own regard. I never want to label anybody in any way, shape, or form. I identify myself as someone who is disabled, but other people may use any of the other words from this list here. Other people may find something from this list offensive in their regard, but that's something that's on them, and it's up to them, and that's something for them to also then in return, let you know. If you call them something, maybe you call them differently abled, and they don't like that. Well, then that's something maybe they'll let you know and say, hey, I don't like to be called differently abled. I like to just be called impaired, mobility impaired. That's something that is based on the individual and understanding the individual and what they're coming from and their background and how they use identifiers in their own life. In that regard. So kind of talk about common disabilities as a whole. Slide. These are kind of the 5 main types of disabilities. If we were to kind of break it down, can you see it all?
Yeah,
I'm blocking you. I'm like,
No, you're fine.
playing a game with you
I'm
over here.
using-
Okay.
Right here.
Yeah. I can like banana myself over
Thank
for
you.
you. You need to, like, I got you. Just let me know. But yeah, these are kind of the main types of disabilities. You know, we kind of group mental disabilities as the kind of the new term is neurodiversity. Obviously, physical disabilities regards to physical impairments, medical disabilities we'll get to in a little bit, and then there's a hard of hearing and deaf category as well as the visually impaired. So those are kind of the main categories when it comes to disabled and how kind of disabilities kind of align themselves. So starting with neurodiversity, this is kind of a newer term, but it encapsulates so many different types of people. You can kind of see it in there. The autism spectrum disorder is on there. You've got dyslexia, things like OCD, ADHD is on there as well. People who are gifted. There's a lot of sensory-related disabilities that fall under neurodivergent. Neurodivergent, you know, there's a lot of really great testing that's been done lately and understanding people and kind of, you know, playing to their advantages, understanding that, you know, taking it as they get, you know, that they are, and understanding, okay, they are maybe ADHD. And utilizing that and understanding, like, how can we help somebody, not treat somebody, but how can we help somebody with somebody who has ADHD or anxiety or OCD kind of move forward and use their skill sets as an advantage and play to that in such a regard.
Good.
So what's really awesome is with all the testing being done and all of the, we're finding more and more Americans in general actually fall into the neurodivergent spectrum. Roughly 30 to 40% of Americans today fall within the neurodivergent spectrum, which was kind of listed in that previous slide. So I think it's good to know as this population grows and has an understanding and an acceptance of, like, you know, going and, like, you know, really going in for those checkups, making sure, like, finding out, like, hey, I do fall on that spectrum. And having that understanding to be able to move forward and live a healthy life, live a long life, and a life that they understand what their limitations are, but also maybe what their gifts are that they're able to utilize and prop up because of falling within the neurodivergent spectrum. So I want to talk about the other kind of 3 categories here, or 4 categories technically. So physical disabilities, these are just a couple of them. I know that Scott has talked about some, but I mean, there's obviously, so there's spinal cord injury, as he talked about, spina bifida, cerebral palsy, cystic fibrosis, dwarfism, amputees. A lot of these, you know, some of them are from birth, some of them are later on in life. Medical disabilities, this is one that's often, I don't want to say ignored, but not often thought about. You know, things such as diabetes, heart disease, seizure disorders. You know, these are independent disabilities of other disabilities, and these are, you know, I don't want to say treated, but recognized in their own nature of, you know, maybe, you know, you have something in the physical disability, but then you may also have something in the medical, and to kind of view these as independent, to understand kind of the background, what we can do to educate ourselves on certain disabilities within subcategories. And understanding kind of the limitations as well as what to be expected when it comes to having certain disabilities. And then the last 2 categories comes with, like, visual and hard of hearing disabilities. And so we've got deaf, hard of hearing, visually impaired, blind, colorblind, as well as albinos. And so all of these people fall within kind of those categories. So those are kind of, like I said, our main categories. Obviously, there's several more disabilities that are not listed in these. These are just a couple that fall under each of these different umbrellas. This is something, you know, especially in the medical field here, you know, being in a hospital and all, is just like how much, because of all of the surgeries, especially kids who have spinal cord injury or spina bifida, they actually have a very high percentage of sensitivity and or high allergic reaction to latex. Roughly 18 to 73% of children and adolescents have the sensitivity to latex, whereas over 60% of adults with spina bifida have a latex allergy or some form of sensitivity to it. And so that's something to acknowledge when working in this. And not only like here in the hospital, but like when you think outside of the hospital, you know, you go to birthday parties, you know, latex balloons. You go to, you know, go play around in a basketball court. A lot of like kickballs are coated with a latex coating. And so these are all things to kind of consider in those kind of environments with those kids. And so it's one of those things like, you know, making sure, you know, if you have, you know, one of your kids has a birthday party and, you know, making sure that if there's a kid who may have spina bifida, that's something to be acknowledging when it comes to this, or even, like I said, playing, you know, on a playground. A lot of, like I said, kickballs, a couple other different types of like sporting equipment have that latex coating to it. And so that's just something, again, to be cognizant of kind of in everyday nature, everyday life, how many things actually have that kind of latex coating to it. So, you know, if you talk about, I said earlier with, you know, neurodiversity about how more and more people are getting tested for different types of disabilities. Right now, looking at the entire world, roughly 15% of the world has been diagnosed with some form of disability, which seems incredibly low compared to when we were talking about, you know, here in the United States, but this is the record of people who have officially gone out across the entire world and have been tested and have come with a diagnosis of one form of disability or another. And so it's kind of powerful to know where the world is at and where we are as a country. You know, we talk about like neurodivergency, you know, there's 60% of Americans who have neurodivergency. We're very strong on testing. Here we are in, you know, a great hospital setting where there's a lot of, you know, great resources and testing people are getting out there and trying to get more people, you know, to get the resources they need to be successful and understanding their situation. So,
There you go.
yeah,
There you go.
you jumped, that's cool. So I want to talk about like terms to avoid and kind of like, go to the next one.
All right.
You know, when it comes to like the, you know, what do you identify as a disabled person? You know, we talked about that earlier. There's also like terms to avoid. And this is, again, more of a case-by-case basis. Some people use terms more than others. I mean, I kind of came up with a list in general of terms that, like, ideally, as a society, we should kind of look to avoid. Like someone who is of a short stature, you know, try not to use the word midget. You know, the word retarded, you know, really should be done with. It's frustrating how much that is still used. You know, when it comes to people who are hearing impaired, you know, we try to look at it as not someone who is mute, someone who is disturbed. You know, people with other types of disabilities, we don't like to use the term spasms or spastic. You know, that's not an appropriate terminology to use with those disabilities. It's kind of more of just a component of their disability. Yes.
Like in this environment, we use the term spastic to talk about a person's muscle activity and talk about their muscles, but we don't like call
Exactly.
it that. Is that what
Yes,
you're saying?
and that's exactly it. You know, thank you. Yeah, so I would never, you know, you never call somebody, oh, she's spastic. You know, you never say she's spastic. But when you're talking medically and saying, okay, she may have some muscle spasms,
Right.
you know, that's more, again, appropriate in that
Okay.
regard. Yes, absolutely. And then, you know, talking about, you know, I know kind of the term autistic, you know, we talk about the autism spectrum. You know, just simply say someone is autistic, you know, maybe kind of that same example of what she just said, you know, they are on the autism spectrum, but they are, you know, not to say they're autistic. And also kind of the terms in like the negative connotations, trying to remove the barriers of like saying victim, you know, someone is a burn victim, or someone is a, any form of kind of victim of whatever because of their disability. We try to say like more of a survivor, more of, you know, they've grown from it, and trying to change that narrative into a more positive front in regard. And then the next term was visible disability. And I don't mean that as in like visually impaired. I meant that as saying that someone has a visible disability. Oh, they're visibly disabled. You wouldn't say that about any other demographic. You wouldn't say, oh, she's, you know, visibly black, or oh, he's obviously gay. You know, you wouldn't say that in other situations or other departments, you know, same way that you'd say with disabilities, because there's a lot of, you know, disabilities that are not visible. And having that kind of understanding that we don't say that, oh, she's visibly disabled. You know, and trying to remove that of that stature, if we know, for example, someone has a certain disability, you may say, oh, she has spina bifida, and trying to change that narrative in that way instead of like, oh, she's visibly disabled. And then I got this to this, I know I said it in the previous slide as maybe a term to use. I don't love the term wheelchair bound because, obviously you guys deal with it here in the hospital. No one is bound to their wheelchair. They're not in their wheelchair 24/7, 365. They get out of their chair to go to the bathroom or go to the shower or to go to bed. They don't sleep in their chair. And so they're not bound to their wheelchair. Kind of again with that negative connotation concept, that you're never, like I said, bound to your chair. And so, I'm not bound to my chair either. I get out of my chair as soon as I get home and I scoot around on the floor and that's how I get around. And so using, that term wheelchair bound kind of sets that limitation, that kind of confines them in such a way that makes them sound like there's nothing more for them. We've got some really great sporting equipment here in this room, with bicycles and stuff. They can easily get out of their wheelchair and go take a bike around the block. That type of stuff. So, that was kind of a strong word for me, is that concept of wheelchair bound in general. So, kind of go to the next slide. Talk about interactions in general. The first one is just chivalry's not dead. I know, we're in this, age of, sensitivity, and like I'm all about sensitivity and being able to make sure that, you're not overstepping, you're not offending. A lot of people, and I get it, you don't want to offend somebody. You never don't, want to be like, do something and be like, oh, I'm so sorry. I didn't mean to do that. And so but it's okay. Chivalry's not dead. It's okay to help, but ask first. Ask, hey, can I help you open that door for you? Or hey, could I help you open that bottle of water? That type of stuff. Try to ask. Honestly, it really is more appreciated than you'd expect. I appreciate, could I open a door myself? Yeah, totally, 100%. But do I appreciate it when somebody opened the door for me? Think of it also yourself. Would you like some help with somebody opening the door for you when you got a bunch of carries? Ask them and then do it. And just and then know that every disability has its limitations. As I said with myself with opening a door, I can open the door. I know my limitations. I know what I can do and what I cannot do. And everybody has those limitations and situations in that regard. So understanding, how to approach that, because that might be something that they like to do. That's something that gives them independence and power to say, I can go open that door myself. I may use a wheelchair or a cane or whatever it might be. It might take me an extra, 30 seconds to open the door compared to one of you, but that person's going to open it, and because they're excited, they're going to feel powerful because they did it. Because maybe 6 months ago they were, lying in a hospital bed and they couldn't move, and now they're just excited to be able to walk through a door themselves and open it. So, like I said, it's appreciated more time than you think, and just ask when it comes to that. On that same breath, asking questions is cool. We're never done learning and understanding. That's why we're here, right? We're here to learn. We're here to understand. One thing that I always like to ask myself when it comes to even asking anybody, regardless of their background, is I like to call it the mom test. Would you ask your mom this question? I like to always, is this an appropriate question that you would ask your mom? And there's been countless times when I have been asked, very inappropriate questions that borderline on the sexual harassment and whatnot, because they were curious. And I totally, there's a boundary between curiosity and just being plain inappropriate. And so, I try the mom test. Try it yourself when you're, helping somebody out with a disability or whatever it might be, or even not even disability related. It's somebody from a different culture, and you want to understand what their, situation, or want to ask them about something. Ask yourself, would you ask your mom this, or a parental guardian? If the answer is no, then maybe not. Maybe that's one we avoid. Yes.
I have to go see a medical student, but so the typical question that comes up, and I don't even know the answer or what is an appropriate thing. People have the curiosity, or they really want to know or have a connection with you and say, how did you get your disability, or how did you lose all your limbs? When is it appropriate, and what will be the best way to approach it?
Yeah, a great question. I think that's one of those things as you build a repertoire relationship with somebody. You know, as you get to know somebody, you know, it really is also based on that instant connection. Like, is this person, like myself, an open book, an open mind, they'll answer basically any question, or is it somebody that you can tell just from your own intuition, maybe they're a little bit more closed up, maybe they're a little bit more kind of not comfortable with answering questions right now. So that really comes down to like understanding the person and knowing, you know, how far can you, I would say, take that conversation. You know, if there's a connection there and if there's a situation and you see it moving forward, that they seem comfortable, then yeah, I would say ask that. But it really is kind of, like I said, based upon their own comfortability with you. You know, if you, and I think that kind of goes back to you as well, is if you come off yourself as someone who is willing to answer questions in return, and is willing to be open-minded and respectful of them, I think they will in turn do the same to you. You know, I wouldn't lead with that. You know, like the first time, you know, I've had that situation where people have come up to me and be like, what happened to you? You know, like that's not okay. You know, but you build that relationship, build that repertoire, even if you're just meeting this person for the first time, you're only going to see him for, you know, 10 minutes, you know, ask some other questions first, you know, and get to know them a little bit. And like I said, based upon how comfortable you feel, you know, I don't want to say you can always ask if it gets to that point, and then respect the fact that if they say no, it's no. You know, so it's really dependent on the rapport that you build with that person.
Thank you.
Thank you. You know, this also goes the same with kids. You know, kids being kids. You know, a lot of people have kids. Kids will ask some weird questions. I have had countless weird questions like, are you a robot? You know, like, like, you know, like those kind of questions from a kid. Like, obviously, no, I'm not, just so you know. But, you know, kids will be, and I just don't want you to ever shame a kid, you know, because, you know, as we talked about in a previous slide, like, we're always learning, we're always growing, we're always evolving. That's how human nature is. And so, you know, as much as adults have questions, I'm sure kids have just as many, if not more. And so I just don't ever want people to feel like they, you know, that shaming a kid is okay. Because kids should be able to ask questions. And I don't want you to ever feel like you have to shield that kid, you know, from asking questions, or feel like, you know, you're scolding them for trying to ask questions. You know, I typically myself, if I see a kid staring or, you know, curious minds wandering, I'll go up to them and say hi and start that conversation. But I never want a kid to feel like they can't, because you know, they may experience disabilities later in life, whether they have a classmate with a disability, maybe not in elementary school, but maybe middle school they meet a kid with a disability. You know, or even, you know, when it comes to disabilities, sometimes disabilities happen later in life. And, you know, this kid might be curious about wheelchairs and stuff like that when they're 5 years old, and then all of a sudden acquire a disability at 30 years old. And, you know, here, then they learn that knowledge in advance, and they learn about culture, they learn about that diversity early on, so that, you know, they have that. And so I just never want, you know, people to feel like they can shame those kids for asking those questions. Obviously, you know, work on them, and even after the disabled person or whatever it might be leaves, you know, ask that kid follow-up questions, like, oh, what did you think talking to him? What would it, you know, did you have any other questions, or, you know, how did you feel about the answers to those questions the kid, you know, that you asked him? You know, kind of continuing that education after the interaction, I think is super important when it comes to kids, because their mind's still going to be racing. You know, even after I leave, they're still going to be asking questions. And so, you know, keep that dialogue open. I think this is, like I said, not only disability related, but culturally related as well. You know, you talk about any other kind of diversity, you want to make sure that you keep the dialogue open for when they come into the interactions. You know, here we are in a bigger city, so you're going to have more of that diversity. You're going to see more people with disabilities. There are different races, ethnicities, sexual orientations, et cetera, et cetera. You know, they're going to see this more, and they're going to have those more questions, you know, being here in a bigger city. So let's talk about being cognizant and kind of things kind of in general. So, like, things help without being intrusive. You know, like, I kept bringing up the concept of holding open a door. You know, there's a right way to do it, and, There we go. Well done. There's help without being intrusive. You know, one of the things that I hate is, you know, being in a wheelchair, how someone will open a door and then basically try to be like a tunnel, and you're supposed to like crawl underneath them, where they hold the door open and do this. And I'm like, no, we're not doing that game. Like, we're not playing tunnel game here. Or like they'll try to be like in the doorway, and you're like, well, you know, the chair needs at least 30 inches to get through, and your feet are covering 3, so like you want to keep those feet. Let's, you know, step aside. You know, keeping a clear path is kind of going with that as well. You know, being cognizant. You know, how many times, especially my background with architecture, is how many times we'll see trash cans be put right in front of the buttons for the elevators. You know, this is something to be cognizant when you're going around space yourself. You know, that's limitations for so many different types of disabilities. You know, physical, you know, visual, you know, it's a difficulty. You know, with the trash can there, they can't get to the button. And then also, as we talked about earlier, it's not every disability is obvious. You know, there's a lot of people who have hidden disabilities, you know, say invisible disabilities, disabilities that you cannot see in day to day. And so understanding that that person may look like they're not disabled, but they may have limitations, and you may ask them, oh, you know, to do something, and that is actually something they can't do because of their limitations. And so just be cognizant of that when asking, you know, always, again, going back to asking questions, how important it is to remember, even people who aren't disabled, everybody has their own limitations and their own strengths and their own abilities to, you know, move forward in general. Be sensitive about physical contact. There's a lot of times where, you know, people who use canes, people who use different things where, you know, even just trying to like grab their arm while they're walking may actually knock them off balance. I remember there was an instance, I was actually at an international competition in Olomouc, Czech Republic, and I was in a manual wheelchair at the time, and I had handlebars for when I got tired from pushing. And I was trying to cross the street in Olomouc, and this guy, this drunk Czech Republican dude, came up behind me and just grabbed the handles of my chair and just like pushed me across the street, and it terrified me. Absolutely terrified me. It felt like I was being kidnapped, kind of like that Top cartoon. You know, like that's literally like the same thing. It's like if you were about to try to cross the street and someone just picked you up and carried you. Like, I don't know this person, like, you know, uncomfortableness of that. And, you know, being in that situation, you know, just being cognizant about having that, you know, and then also when it comes to equipment, you know, their chair is, you know, in a way their own space, and it's also part of them. You know, how many times I have prosthetic legs that I use as well. And like sometimes, like, you know, we talk about kids being kids, like I'll have a kid come up to me and like kick the prosthetic leg. And I'm like, can you feel that? And it's like, well, yeah. Like it's not like physically part of my body, but like the vibrations and like that kind of like rocks my body a little bit. And like, yes, I can feel that when you kick the prosthetic leg. You know, and know that that's part of them. You know, also with the physical contact, there are certain disabilities in which the skin is sensitive. You know, whether it's a burn victim or somebody with some form of, you know, mobility issue, in which like any form of touch is almost like being, you know, scraped with like heavy nails. And so just any form of contact like that is very uncomfortable to them. And can actually, you know, send them sometimes into a seizure or some form of situation like that when it's unexpected in a situation like that. So just being careful when it comes to physical contact in general. And then always talk to the person who's disabled. You know, how many times I've gone out to dinner and whatnot, and the waitress will ask somebody else I'm sitting at the table with, oh, what does he want for dinner? You know, like, I can talk, I'm here, you know, like, you know, I know what I want, like, hey, like, but like, you know, and also, you know, talk directly to them, you know, talk to the person directly. You know, how many times where, you know, I am a little, you know, lower, obviously being in the wheelchair, and the people will talk above me. You know, they'll be talking to the person I'm with. You know, even that includes people with, like, who are, you know, hard of hearing. You know, talk to that person in particular. Typically, in a situation, their interpreter will actually stand right next to you. And so, purposely, so that you're talking to the disabled, the person who is hard of hearing, so that they can see your lips and they can see what you're saying, and then the person who's translating will be next to them. And so that way you're talking to, it may seem a little weird because they're not answering you in that regard, but you feel like, I don't want to say you're talking to nobody because but they can read your lips and they can see what you're saying, and the translator will do the translating and will communicate back to you, but having that communication between them and having that relationship, yes.
Now, I always want people to be offended if you were kneeling down and just talking at that same eye level or sitting in the chair next to them and talking to them. But you wouldn't feel offended if we got down to the level where you're at so we can do direct eye contact and talk with you.
Now, interesting question. Thank you for asking. It's one of those things where I guess it depends on your initiative of how you're going about it. Because I've had people who've gone down on a knee like that, but then talk to me like I'm a 5-year-old, and so it's kind of the way in which you communicate from that point on. If you're doing it in a respectful manner and you're saying, hey, I want to be down on your level and I'm going to sit in a chair across from you instead of, having me, look up at the ceiling, then I think that would be acceptable, but it really depends on I guess your intentions and why you're going down on your knee.
And if you do the person, so, you're a little more intimate with it.
Yeah, exactly. And if it's for the sake of the intimacy, then, to be able to have that communication like that, then, that's appropriate. But if it's, if it's talking down to that person or making them feel less of a human than they are, then I guess that's where the problem would come into arise.
You don't have to worry about it with my knees. I don't get on my knees. My heart's good.
But even just sitting down in the chair like you are, if you were standing and talking to me and then you went down to your knees, or down to the chair, I would acknowledge that and you're like, okay, appreciate that. So just kind of as a summary, that's kind of what we talked about. There are many different types of disabilities. We talked about neurodivergent, we talked about physical disabilities, we talked about medical disabilities, we talked about visual disabilities and hearing impaired disabilities. Some are more visible than others. Everybody has their own limitations. It's okay to be curious. That's as we learn and we grow as a society. It's okay to be, respectful, but and it's okay to be helpful. Just again, respecting the boundaries of that person and that individual. So that's kind of the end of my little spiel, but I would love to kind of hear from all of you, ask questions, share stories. I'm here, again, the safe space. We're recording this for other people to participate in later on. Scott will share my contact information for people who have questions on the road, but just wanted to open it up to you all at this point. So, yes.
Will you be sharing this PowerPoint?
Yes.
Okay, cool.
Yeah.
That wasn't my question though. For a year during the pandemic, I worked for a person with muscular dystrophy.
Okay.
And I learned a lot about ableism and disability awareness from that person. And then I started working here, which was really great. I was really grateful to have that experience, and I learned so much from them. And there was a slide right during the time the two of you transitioned, but I don't think we talked about it. Could we go back to that slide about using the language you use?
Yes.
Because that person is the one who taught me what was on that slide, and I'm just curious from your perspective as well, using identity first versus person first. I probably
that is how we had it, identity first versus person.
Yeah. Right. So they are the one that told me that it's from their perspective and their perspective. Granted, no one person can represent an entire community, but from their disability advocacy, they were telling me that it's better to say disabled person than person with a disability.
Well, absolutely, yeah. And that's one of those things that I hate to say it, but it is case by case.
Right.
I try when it comes to identifying somebody. You wouldn't say, oh, wheelchair Jonathan. You would say, oh, Jonathan who uses a wheelchair. When it comes to identifiers in that regard, or that quad amputee. Try to utilize that person's name and try to humanize that person, and try to put, I guess, that person first when it comes to that regard. But when it comes to, a person with a disability or disabled person, I think that's more of a case-by-case situation, my opinion.
I'm spot on. I mean, we're still evolving. If you think about the ADA is only 25 years old.
Right.
So we're still evolving and learning as a culture, you know. But as many of you have heard, if you've met one SCI veteran, you've met one SCI veteran.
Right.
The same thing overlaid with veteran. You know, if you've met one veteran, you've met one veteran. And it's building that relationship and how to talk to them. We're all human. You know, a lot of you are familiar with the Myers-Briggs type indicator, and some of you may be into the J, like me, and you're extremely judgmental, and that's okay. That's innate to you. That's you. That's your behavior. The trick or the pro tip for all of this is how you convey that. And are you sensitive and aware of the other person's feelings? Like we say, think first to understand before being understood. And I love a story that Stephen Covey tells, so forgive me if you've heard this. But there was a father and two young kids, and the kids are, you know, 6 and 7 years old, and they're on a passenger train, commuter train, and it's busy, it's rush hour, and the kids are just running up and down the train and bumping into people and knocking their cell phones out of their hands, and half the people on the plane, or on the train, are rolling their eyes at this dad for not engaging in correcting his children's behavior. So they're all judging this man as, oh, what a, you know, bad dad. He's not correcting the behavior of his children. And the whole time the dad's sitting there with his head in his hands, thinking about how's he going to tell his children that their mother just died because they just left the hospital. So, I mean, that's powerful. But you take that with you and just, you know, try to think, try to understand, you know, before you force your understanding upon, you know, who you're talking to. And that's in everyday life.
Yeah. So that's your question?
Yeah, I know it's you can't really like
Yeah.
use one term for a whole group of people, but I was just curious what your
Yeah.
It's evolving every day.
Yeah.
I mean, it would be like the Letterman's top 10 list every day. It's evolving. So it's just that awareness and that individualism. So great question. And come on, I know there's more questions over there. Get a captive audience here. You guys have seen it all. You've seen a lot. You've endured a lot, and you've had to deal with, you know, all the. We don't have the disability or the veteran categories up here with the happy veteran, the grumpy veteran, the mad at the world veteran. But you've experienced it all, and with that, you learn, you know, not just triggers, but what triggers that angry veteran to become a veteran. You know, I'm not going to talk about benefits today because Mr. Jones is going to really go off the deep end that, you know, he's entitled to benefits that he's not receiving, and that's really not your lane. But yet you got to deal with that anger, you know, that anger that veteran's presenting, and it could present a wall or a barrier between you doing your job and that veteran.
Sometimes we have a hard time explaining to our veterans, you know, staffing limitations, you know, there's a lot of guidelines we have to follow to be here compared to the civilian sector. And sometimes they're pretty good about understanding, and sometimes they're not. And sometimes we could have, for example, we could have a rapid response, and we're all tied up because this person has been serious issues. And I know that people are self-centered. We staff and patients both are. And sometimes it's hard to explain to some of the guys, you know, we have to take this particular person away. We have two persons working with you. We have to pull this person to help monitor the rapid response or something any time of the day. And sometimes they have to, it goes both ways, of course, but they have to try to understand that, you know, where we're at.
You're spot on, but the rest of my profile is ENTJ, and, you know, I'll tell someone to suck it up, Buttercup, and embrace the suck. But I can do that, and you can't. So
I'd be in the principal's office before you go.
you got to, you know, toe a fine line in this, you know, medical VA community.
It's getting more complicated every year, and we're trying. Everybody's trying to work through it with staffing issues, COVID. I mean, we can't staff the way we used to. We can't get a lot of the people we need to get in, and then we got to prioritize. And it's stressful for them, and it's stressful for us. If we find that people waiting to get in here, we can't get it because we don't have the
staff that will take care of them.
Absolutely, and what I'll tell you is the same thing I shared with some of the nurse managers. You know, don't get yourself into a situation that's going to become escalated, you know, with the veteran. There's a fine line between calling the VA police and calling Scott, because Scott can intervene and go in there and do more one-on-one with the veteran before we have to call the police, because I am in a volunteer status and in a non-official capacity. I know we've had staff that were spat at here on this floor, and that's just, you know, there's no reason for that.
Sometimes we have to, unfortunately, have to do limit setting, and it doesn't a lot of times go well with the patient as far as trying to set limits. We have, this is what we have to do.
Correct. You're bound by a different set of regulations than I am, and that was my point I was trying to convey is, let me do the ugly sometimes and save you end of that. Please, Donna.
I'm wondering if you have suggestions for us as we work with veterans who have, are in different stages, either with a brand new injury or they've been living with their disability, if you will, for decades. Do you have specific suggestions for us for how we can help people adjust and, you have something to say? Yes. And Dr. Williams can talk to this, and Dr. Brundage too. We have a phenomenal peer mentor program, okay? And the books that you guys have received are the hard copy of the Christopher Reeve Foundation Paralysis Resource Guide. And the Reeve Foundation has a peer mentorship program as well, and they match veterans with new SCIs with a like peer, or even the family members, to kind of help step them through the different stages that they can anticipate or that they will be going through. And that's just a phenomenal resource. I can't say enough about that peer-to-peer interaction. Dr. Williams, I'm so sorry, go ahead.
No, but I also just want to speak on that. I think part of it is too is just letting them kind of find themselves for a second and just be patient. You know, I think when it comes to people, I volunteered, or 2 years in a row I was living out of the Olympic Training Center to help with the Wounded Warrior Games. And it was a phenomenal experience with a lot of the veterans. And I think part of it is taking a step back and seeing, like, what can they do, what cannot they do, and what do they not want to do. And being able to classify those, and maybe that's something that I know in a situation like this, you gotta be quick on your feet and make a decision quickly. But there are some times where, like, you can actually just understand what is normal for them and what is something that is not normal for them. And having that understanding, I think, is super important, and knowing, you know, something that, you know, you can see, especially if you're working with somebody for long term, and understanding, like, okay, they normally walk with a limp like this, but maybe if something is wrong with them, their limp actually changes. And that's something that you can tell as someone with a disability, and kind of understanding, like, how they progress and how they are, and kind of understanding, I guess, where they are in their process with someone who's just brand new with their disability versus somebody who's also had a disability for like 30 plus years. I think is super important in that regard, and understanding the disability that way. You know, with that same breath, I think it's also important to kind of see, like, you know, making sure they're not pushing themselves too hard in a way that actually then leads to further disabilities, because, you know, maybe they are, you know, stubborn in one capacity or another. And so just kind of, sometimes it's just even better just to take a step back for just a second and understanding, like, what are they working with, what do they have, and then kind of knowing, you know, what are they comfortable with. Because there are times where, like, you know, there's something that, you know, you may learn from them about, you know, their abilities, you know, even if it's, like I said, a pretty fresh disability, that, you know, there are certain things, like, people who are freshly amputated because of, you know, especially in the situation because of the being a veteran, where, like, their amputated limbs are very sensitive to touch, and you cannot, you know, even just putting a blanket on their legs is the most painful thing on earth. And so that's something to be cognizant of with certain disabilities, when, you know, someone who's, you know, fresh with a disability versus someone, you know, and a little bit further. And so, you know, you talk about peer mentorship programs, there's a lot of really great resources online as well, you know, to help them self-educate. You know, I always advocate for self-education and education, because I think there's so much that they can learn independently especially if you're dealing with people who are stubborn, don't tell them, oh, go read this article. Allow them to go, hey, here are some really good resources. And here's a peer mentorship program, kind of that you can, bring a horse to water, can't make it drink it kind of situation. Like, give them the resource to the peer network program. Give them the resource to Wausau or Glassau or, a different program or any form of, but, they may not do it, and it's okay. But at least, providing those resources, because it might be something that may be helpful.
Jonathan's spot on. You're gonna get a good laugh out of this, but 13 years ago, when I did my intake on the 10th floor, for the second time I had my spinal cord surgery, I kicked the PVA rep out of my room. Wouldn't talk to him. I'm not one of you. I don't want anything to do with you. So, 3 years later, I joined the organization and have since evolved. So, it's critical time, that new injury and accepting, your new norm as a disabled person. It's a lot to process. It truly is. And we're all uniquely different because we are human. So. Great questions.
You mentioned Wausau and Glassau. What are those?
Those are disabled sports organizations. So Wisconsin Adaptive Sports Association. It's out of just north of here.
It is.
Is it?
In Dr. Lee's living room, but
Everybody I thought it was well, they did a lot of activities up and around here when
they move around and
that's
use
true.
different facilities, and then Glassau.
Great Lakes Adaptive Sports
Association.
is out of Kearney, Illinois is where that one's. They were based at the Navy base, yeah.
If you're curious about things like Glassau and Wausau and like PVA and like things that people that you take care of, it is on PVA's calendar. You go on there, you can see it. You can go check out wheelchair basketball and stuff like that.
Oh, yeah.
So I don't know what you guys have access to, but just to remind you, like, if you're curious what some of these things really are because you've never exposed yourself to it, highly encourage it because wheelchair basketball, it's huge. For me personally, when I was at Walter Reed dealing with cancer and had mental health issues, and learning how to walk again. I know what sports can do for me, but you don't know what it can do for one of your patients if they're able to, you got to do that case by case. So that's why I say
it's not just veteran-centric, it's for any person with disabilities, children and adults.
And I know there's another one out of the Madison area. There's a Dane County, one as well. So
There's STAR, which is up by La Crosse. There's Adaptive Adventures. There's Dare to
Yeah.
Try.
Wow.
The Wounded Warrior Foundation. There are a lot of organizations. We're meeting with most of them next month up in the Wisconsin Dells to kind of collaborate and share calendars. As Darren was saying, our calendar on our website is a Google calendar. We feed the rec therapy calendar, we feed the Glassau calendar, and the Wausau calendar are through our calendar on our website. So every day there's multiple opportunities for participation and for volunteer support for these activities as well. As you know, kind of our capstone activity is the National Veteran Wheelchair Games. This year will be in Portland in July, and some of you had a chance to go to that and experience that. Michelle's gone for many years. It's a great time. I've gone for the last two. And it's kind of a phenomenal capstone to see the athletes come together and compete in the camaraderie and the peer support. And it's just constant cheering and motivating everybody. It's just a phenomenal experience.
There's always volunteer opportunities with those two. They're always looking for people to run stopwatches, get water bottles, check people in, registration, that kind of stuff. So if you're ever just interested, and that gives you more exposure and more ability to learn.
We had a pretty good, Dr. Dugan and the crew did a pretty good bang up job when we had the wheelchair games here.
Absolutely.
Oh, it was fun.
Absolutely, yes. We won't talk about getting back to Milwaukee. Next year it's going to be.
Wish before he retired. I think
No. We've had that conversation. Next year it's in New Orleans, and then the year after that it's in Boston. So it's already planned out for the next 3 years. We do a mini version. We call it our Adaptive Sports Boot Camp. That'll be done in Franklin at the Milwaukee County Parks Sports Complex off Bryan Road, 16-17 May, I believe.
pickleball, football, basketball, bocce ball, all sorts of adaptive sports, wheelchair obstacle course, some adaptive fitness with a really cool trainer that Michelle knows very well that does brings in some cool jungle ropes and lights that the veterans have to touch, and it's a good opportunity, good fun, and we always need volunteers for that. So, any more questions, please? I can talk for days about volunteer opportunities and fundraising and all sorts of stuff. We welcome the opportunity to be the easy button for you, for the staff here. Roxanne knows, I try to help break through all the VA bureaucracy and red tape that I can, but we are limited by that. You are confined by that. So I try to bring logic and sensibility in when I can. Yes, ma'am.
So I know that for like the big wheelchair days events and like the conferences and stuff, that the PVA helps to facilitate some of the staff from here being able to participate. If we wanted to volunteer like in our own time for like more like local events, like you were saying, the thing in Franklin or other smaller things, do we just find that information on the PVA website?
Absolutely, WisconsinPVA.org.
Okay.
Yep, volunteer opportunities.
Thank you.
Yep.
Hey, something to think about with the sports stuff too. So, kind of bring back my story when I was at Walter Reed. Not in a good mental health place. Someone got me to go to the gym one day, sat in a chair. Like I was already in a chair, but put me in one of the wheelchairs for wheelchair basketball, and it pulled me out of a funk, a really deep funk. My point there is, you guys can too go sit in those chairs and roll around in them, and play some basketball. It gets competitive. It's fun. If you need a workout, it'll work you out because, it's great and it's competitive. Like, I encourage you to do it because you don't know what it's going to do for you. Like, and it also puts you in the chair just like your patient. The old adage, walk a mile in a man's shoe kind of thing. That's my point, is it's a chance for you to kind of come down to that level and just say, hey, what is it like to have to overcome these things and deal with these things? So it is an opportunity for you to potentially do some of that stuff.
I would still do stuff with conjunction with the national PVA, with far as we used to have the bass tournaments and the track and ski program. You said got a lot of guys that would travel around the country for years.
Right. The National Trap Circuit will be brought to Green Bay June. I don't have the exact date on my head, but it's in June at the Brown County Sportsman's Club. We do Samarama in July. That'll be July 19th. We charter 10 boats. So we always need assistance, able-bodied person assistance in helping get the veterans on the boat. We have foyer lifts that we're putting at the marinas to get chairs and the veteran on the boat, and we're offering dry land fishing as well, because as some folks found out last year, 4-foot swells on Lake Michigan are not for everybody.
So we're talking about the one that June one up in Port Washington?
There's one in Port Washington that's done by another organization. Ours is Samarama down in Racine. But I'm glad you're smiling, because your smiles are infectious. And take those back to the floor, because you will make a difference. Your attitude, human nature, people are primed by watching other people. It's proven that if I walk by your office door really slow about 20 times, you as an individual will move slow, just because you're primed by that behavior. So trust me, your attitude and your smiles are infectious and can really make a difference in the lives of our veterans on the floor. As you know, we have veterans who should be in long-term care facilities who are kind of stuck here on the acute care floor, and their quality of life sucks. There's just no way to sugarcoat that. They should be in a long-term care facility. Now, I'm not saying it's your fault that it sucks. I'm just saying their situation sucks. Right. So anything you can do to make a difference in any of those, veterans' lives is huge. And I know it's challenging, and I know it's difficult. It does make a difference. I can talk all day. I was an instructor in the military for 20 plus years. I taught leadership development. I taught MBTI, Myers-Briggs Type Indicator. I taught personality dimensions. I Trust me, I can go, just wind me up and give me some coffee. If you have any questions beyond this, reach out to us. I'll share my contact information with Tara and Taylor and the presentation. It'll go out. My email address will go out. Jonathan's email address will go out. Please ask